Po at magandang araw po sa inyong lahat. Ako po si Dr. Buenaventura. I'd like to thank the UERMMMC Department of Psychiatry for the invitation to be one of your speakers this afternoon. I feel very fortunate to be able to share my experiences with you regarding the psychosocial concerns of the elderly during the pandemic. Let me cite an actual clinical case. Middle of last year, a colleague teleconsulted with me regarding his elderly mother, a widow living alone with one maid, who presented with atypical manifestations of depression focused primarily on somatic symptomatology that started late April 2020. His mother did not use a cell phone nor the internet and could not therefore avail of teleconsultation herself. Allow me to go through some highlights of our conversations via text messaging. I have to add that we also had voice calls via Viber. In one of his first text messages, my colleague wrote, "Hindi na kasi magawa yung usual routine, weekly parlor, movies, mall, group and religious activities." I reviewed the history with him and he added, "Tingin ko nga dahil sa pandemic na ibang routine niya, ayaw niya naman lumipat sa sister ko. Gusto niya rin nag-iisa para may magawa daw." He obtained additional information from his sister, who was in contact with her mother more often, and she texted, "Mother told me she is lonely since the lockdown started." And she added, "Dati lumalabas kami twice or thrice weekly, watch movie, eat outside, plus shopping and attend Bible study and CCF on Sundays." There was a remarkable change in her activities of daily living, and she was cooped up in her home, unable to go out, and fearful to have visitors over. Since she also had a lot of anxiety complaints, I started her on a low-dose anxiolytic as a prelude to eventually initiating a low-dose antidepressant. I had additional discussions with my colleague and explained to him that the elderly are particularly vulnerable to the anxiety and depression brought about by physical isolation or distancing due to COVID-19. In his mother's case, the drastic curtailment of her means of enjoyment were aggravated by a drastic reduction as well of physical contact with loved ones. I shared my own experiences with other patients and even those with my own mother about accompanying her to Mercury Drug Store while my sister brought her to the mall, but always protected with a face mask and a face shield with frequent hand sanitation. Thus, we came to those strategies as well for his mother. Pwede bang ipasyal kahit sandali sa mall with all the protective gears para magkaroon siya ng idea about the real situation outside? And as soon as ECQ transitioned to GCQ, they were able to bring their mother out and she was able to resume some of her previous activities. As a result, she texted him, "May improvement na. Nag-walking na ako kahapon. Sana tuloy-tuloy na ang paggaling ko. God is good. Thanks for His love and faithfulness." I saw this patient last night as part of her regular follow-ups, and she remains well after 12 months of treatment, and we are now in the process of tapering off her medications. Let me put one thing in perspective. There are a lot of elderly Filipinos right now. In 2010, the elderly comprised 6.8% of the total population, equivalent to about 6.3 million senior citizens. 5 years later, in 2015, the proportion rose to 7.5%, or about 7.6 million elderly individuals, an increase of 1.3 million elderly Pinoys. I have projected that for 2020, we had about 9 million elderly individuals, making up about 9 to 10% of our total population. A slight majority are women, and we're looking at a life expectancy of 71 years, just slightly below the world average of 72 years. Based on recent COVID-19 data, we can see the data for confirmed cases, fatality rates, and recovery rates by age groups. The elderly comprise only 9% of the population, as I've mentioned, but 13% of all cases and 64% of all deaths, and they have lower recovery rates. Thus, we can see that the impact of COVID-19 is disproportionately worse for the elderly. In fact, almost exactly 1 year ago, the case fatality rate for the elderly was only at 57%. In any major health crisis, fear, worry, and anxiety are expected and common responses. Based on the COVID-19 experience in China, the number of adults across all ages complaining of anxiety, depression, and insomnia increased dramatically, especially for anxiety and depression, in which the increase was about 5 to 10 times. Another study has shown that specifically for the elderly, the number of individuals affected by anxiety and depression was remarkably high at about one-third of the elderly population, and this was associated with market distress. In the US, a similar pattern emerged. Based on prescription data for anxiolytics, antidepressants, and hypnotics, there have been an increase since a national medical emergency was declared early last year. As you can see, from a period of 1 month, the increase has been remarkable. 34.1% for anxiolytics, 18.6% for antidepressants, and 14.8% for hypnotics. These are remarkable because the trend for anxiolytics and hypnotics had been decreasing in the preceding 5 years, and then suddenly, because of COVID, there were spikes in the number of prescriptions. So the question that comes to mind is, why are the elderly more emotionally impacted by the pandemic? Allow me to share a case vignette. This case is very typical of most of the elderly consultations I have seen during the past year and a half. The patient is a 65-year-old male, married, recently retired operations manager who consulted online due to difficulty of sleeping of about 1 month duration. The patient's symptoms started midway through the ECQ as gradually developing insomnia, characterized mainly as early morning awakening with inability to go back to sleep. He was aware of the changes mula nang magka-COVID, he said. Other symptoms noted were poor appetite, which he described as walang gana pag di nakakatulog ng mabuti, associated with some weight loss and what he described as mabigat ang ulo, loss of energy, poor concentration, and restlessness. He also noted constipation since he had not been eating well. He also tended to ruminate about his insomnia and constipation. According to the wife, he was noted to be always in deep thought, worried that his wife and daughter would get infected with COVID and that they might bring it home to him. He was also noted to have crying spells, and he also verbalized wanting to die. Before the lockdown, the patient could sleep like a baby. He said, paglapat ng likod sa kama, maya-maya naghihilik na. He also had a lot of activities like playing basketball, biking, meeting up with buddies to share stories or a drink or two. But since the lockdown, other than bringing to and fetching his wife from work, there was little else for him to do at home. Symptoms appeared to have gotten worse over the last 2 weeks prior to first consult. Later, we'll talk about the disposition of this case. As we have seen from our local data, the answer lies in the fact that the elderly and those with serious medical illnesses are more vulnerable, and this creates considerable fear and anxiety among them. In particular, those with neurocognitive deficits may be more at risk and therefore will need special attention. One issue is the limitation of their mobility, which is more distressing for those who are quite self-sufficient. And this included being banned from going out of their homes and prevented from entering public places like groceries and supermarkets. For some seniors, they had no choice but to break quarantine to find ways to support themselves or even help others. Another issue was in terms of their health care. Considering that a lot of older folks have one or more chronic medical conditions, regular visits to their physicians were very critical, but these were curtailed, not just because they couldn't travel, but mainly because they would have nowhere to go. A 69-year-old woman with thalassemia told me that her greatest source of anxiety during the lockdown was that she could not see her hematologist. We know that physical distancing is an essential component of preventing the spread of the virus, but when applied rigidly, it would result to isolation, affecting vulnerable groups, including the elderly. Let me emphasize that physical distancing does not just involve staying 1 or 2 meters away from another. It also involves isolation and quarantine. And when prolonged or used unjustly and inappropriately, it can result to loneliness, worry, and cognitive problems. Research has demonstrated that social connectedness and engagement with other people are important to promote successful aging, but that is being directly challenged by physical distancing policies, as evidenced by the experience in China, which is why it is important for policymakers to consult with the end users to ensure that their needs are met, because the experience in China would have been our experience as well if the IATF guideline regarding the elderly was not changed. And because social isolation or disconnection not just leads to emotional reactions, but also to physical problems as well. It becomes a vicious cycle, so we would have more to contend with. An interesting aspect that was noted in the Philippines was regarding going to church. The quarantine period also prevented the elderly faithful from attending church services and observing traditional practices, thereby increasing their sense of isolation, since going to the church on Sundays was frequently the only time they went out of the house. Early last year, I attended a global webinar sponsored by the International Psychogeriatrics Association. One of the speakers was from Italy. The experience with COVID-19 patients was truly saddening. The speaker said that at one point during the pandemic, the elderly did not want to be brought to the hospital anymore because they expected they will be away from their loved ones and will be at the bottom of the hierarchy for treatment resources. They thought that if they were going to die anyway, they might as well die at home with their loved ones. The webinar also highlighted the issue of ageism in COVID-19 treatment and the need to respect the rights of the elderly during the pandemic. The Italian speaker also mentioned something that I thought was very profound, that we should also consider not just the patient's quality of life, but also their quality of death. In the Philippines, once a COVID-19 positive patient becomes hospitalized, they become isolated from their family and friends, with contact only through digital means if available. However, when their condition deteriorates, any form of interaction with the family disappears, and when they pass away, their remains are almost always immediately cremated. It is only that their ashes that the family receives eventually. This situation thus prevents the loved ones from grieving sufficiently, and often there is no closure. These are important aspects that we need to consider as well, part of the psychosocial support we need to provide to elderly patients and their families. Last year, Dr. Melissa Mariano and I conducted a survey on the psychosocial impact of the COVID-19 pandemic on the mental health of elderly Filipinos. Briefly, the survey involved elderly individuals accessing it online via Google Forms. The survey included two screening tools, the PHQ-9 for depression and the GAD-7 for anxiety. Herewith are the preliminary results based on 262 respondents. In terms of severity distribution in the depression scale, the majority of the respondents rated their symptoms as normal to mild, However, about 9% can be considered to have clinically significant manifestations. It is also important to note that in the Philippines, the overall prevalence of depression is only 3.1%. In terms of severity distribution in the anxiety scale, the majority of the respondents rated their symptoms as normal to mild. However, about 8% can be considered to have clinically significant manifestations. It is also important to note that in the Philippines, the overall prevalence of anxiety is only 3.3%. There is also a wide variety of other manifestations that include insomnia and somatic symptoms, which have become very common reasons for consultation. The respondents of the survey also selected the reasons for their increased anxieties. As you can see, uncertainty about the future and fear of oneself or loved ones getting infected were the top responses. Let me now share a few practical tips that most individuals can do to lessen the psychosocial burden of the pandemic. There are a lot of ways, but the following are key recommendations from current guidance and research for healthcare workers supporting patients with COVID-related anxiety and quite useful as well for individual self-care. These come from the Center for Evidence-Based Medicine of the University of Oxford in England. The first is regulating exposure to COVID-related media. Limit exposure to social and mass media reporting on the pandemic, and use trusted resources to access information about COVID-19. Next, maintaining a strong social network. Connect with family and friends via the telephone or internet, and support others as well in the community, particularly those who are isolated. Third, looking after their body and avoiding unhealthy coping strategies. Take care of one's physical health, eat healthy, sleep well, exercise regularly. Finally, focusing on the mind via self-care techniques such as stress management, meditation, and mindfulness. As far as coping mechanisms of our elderly respondents are concerned, caring for the self, praying, and being positive and hopeful were their top responses. Additionally, these are things that we can do for them, and I've extracted most of them from the resources I will mention later on. The first is to monitor their health. Make sure that they are taking their medications, eating right, sleeping well. This is the most basic. Provide help with practical aspects of daily living, such as buying their groceries, cleaning the house, paying their bills. Next is to provide simplified but comprehensive information, including safety precautions or explanations about the IATF guidelines. Ensure regular and consistent contacts with family and friends via messaging services and even the tried and tested landlines. Assist with access to digital technology, including telemedicine consults. Help them develop and maintain a daily routine that can include exercise and other physical activities. Next would be to filter access to mass media and social media. Have someone to talk to, which would be the best thing actually. And then finally, reassure them that what they're feeling is normal. I don't want to reinvent the wheel, and the resources listed here have already provided comprehensive steps in helping the elderly. You may Google them for additional details since I'm not going to go through them one by one. From the World Health Organization, these are messages for older adults, people with underlying health conditions, and their carers. Next is from the Interagency Standing Committee of the United Nations. It's a bit more detailed and broader in scope, including some items for elderly individuals with cognitive deficits. Finally, from the Philippine Council for Mental Health, very succinct, just 4 items. Telemental health resources for private online consultations are also available, and these are the two platforms I use more often. As far as crisis hotlines are concerned, we have 3 to 4 major crisis hotlines in the country right now. I'm going to mention primarily the crisis hotline of the National Center for Mental Health in Mandaluyong. The advantages to these hotlines are they are free, they are confidential, and they are available 24/7. And more importantly, they are staffed with fully trained counselors, not just regular telephone operators. The main drawback, however, is that there could be a waiting period before the call can be answered due to the increased volume of calls. They also have upgraded their system and they are now able to accept landline to landline toll-free calls from anywhere in Luzon just by dialing 1553, thus making the service more accessible now to those in need. Based on the data from the National Center for Mental Health, the number of calls have more than doubled from the year before to last year and even today, including suicide-related calls. The Psychological Association of the Philippines in their Facebook page has provided a list of other centers offering free counseling. The list includes centers from different parts of the country. From the original list of 22 centers in April 2020, it has now increased to more than 37 nationwide. So now let us look back at the case vignette that we had discussed earlier. So what have we done with the patient thus far? He was started on low-dose SNRI, or serotonergic noradrenergic reuptake inhibitor, which is an antidepressant, and low-dose benzodiazepine for sleep and anxiety, both given at bedtime. He was provided with psychoeducation and cognitive behavioral therapy, including precautions that can be taken to minimize the risk of infection, checking and correcting cognitive distortions, and increased activities, which includes improved self-care. He had weekly follow-ups, and improvement in sleep and other parameters were noted within a month's time, which have continued on at present. All of us, including our government leaders, need to understand that the elderly is a very heterogeneous group of individuals. Whenever I teach geriatric psychiatry, I point out that the elderly can be subdivided into 3 groups. The young old, which is 60 to 70, the middle old, which is 70 to 80, and the old, which is 80 and above. Each subgroup would be markedly different from others with totally different life experiences. We are looking at a cohort of several generations with varied needs, wants, capacities, and abilities. Thus, to lump them as one single group works to their detriment. We have also seen that symptoms of anxiety and depression are prevalent in the elderly nowadays. However, we have also seen that in 9 out of 10 older adults, the manifestations are considered normal or mild. Thus, in general, they seem to be coping well. However, reviewing the current COVID-19 data for the Filipino elderly is very sobering and disquieting. The elderly in the Philippines constitute only about 9% of the total population and yet comprise 13% of all cases and 64% of all deaths related to COVID-19. This underscores what we already know, that as an age group, the elderly are at a higher risk than any other age group with greater morbidity and mortality for this disease. This has resulted in biological, psychological, social, and spiritual problems for the elderly. But there is a lot that you and I can do to help them, and a lot that they can do as well to help themselves. Thus, it becomes imperative that we all take very good care of ourselves and each other. And with that, I'd like to end my lecture and to thank you for your kind attention. Maraming salamat.